We should be able to finish the ear today. There's a lot going on with the ear. It's more than just an item that you can add jewelry to and things along that line. All you see is the external part, and the middle ear and the inner ear are really where everything is at. And so we're going to take a look at those in more detail and touch on the basics of hearing and balance. Balance is also equilibrium, and the cranial nerve that's responsible for all of this is cranial nerve 8, the vestibulocochlear nerve. We start off this chapter, or this portion of the chapter, with the structure of the ear. We can call what we see the external or outer ear, is what I more typically use. What you notice is the auricle, also referred to as the pinna. It's elastic cartilage covered by skin. Is the entire auricle elastic cartilage covered by skin? No, your earlobe is not elastic cartilage. It's just some CT in that area covered by skin. Because when you actually try to pierce your ear, you'll have a lot more discomfort in the area of the elastic cartilage. Now, the skin applied to the elastic cartilage, is it loosely applied or tightly applied? Grab your pinna, wiggle it around on the cartilage. It's pretty securely, the skin is pretty securely applied to that. It's not like the skin on the back of your hand, not like the skin on your arm, which you can wiggle all over the place. The skin is actually fairly well applied to that area. That elastic cartilage, what do you know about its ability to regenerate itself? It's poor, and it's really poor because it is avascular. So whenever you have any sort of injury or damage to the cartilaginous portion of your ear, can you take that piece that got chopped off and put it back on? No, you can't. So you have to realize that that elastic cartilage does not have any real true regenerative capacity. And so damage to that cartilage is permanent. So those people that actually do piercings in those areas will always have a hole there. Those people that pierce their earlobes, if you don't have it in for very long, you could actually have that hole close off for you. Not so in the elastic cartilage. We see the external auditory or acoustic meatus. That's what we call our canal, and it is full of ceruminous glands. These are modified sweat glands, and they make the product called cerumen, and cerumen is basically what we know as earwax. It's there to be protective, so it has anti-bug, whether it's a real bug or a bacterial bug, properties, as well as nice coating to keep things nice and moist and properly moisturized inside the ear canal. As you go in further with your Q-tip, if you are foolish, you'll actually hit up against the tympanic membrane. It's shaped like a flattened cone protruding into the middle ear, so that means it's pointing inward, pointing medially. But it's flattened, so it's not super pointy. We call that the eardrum. On the outer surface, it's covered by thin skin. So what lines your ear canal? Skin. And it's all thin skin, because where do we find thick skin? Palms and soles. So indeed, this is thin skin. Now, on the inside of that tympanic membrane, we have a cavity. Do you guys remember what lines cavities that are exposed to the outside world? Mucosa. So always remember that. It's cavity, it's exposed to the outside world, so it's lined with mucosa or a mucous membrane. And so if it's overproductive of mucus, because isn't that what a mucosa does? It makes mucus. If it's overproductive of mucus, it can cause you some difficulties with hearing, and we'll get into that in just a moment. This is our giant picture here. Auricle, external acoustic meatus to the eardrum. The eardrum or tympanic membrane is the dividing line between the external ear and the middle ear. So now we're into that middle ear area, and we're going to take a look at the little bones. Ossicles is the term for little bones, auditory ossicles, and other components of the middle ear that's very important for function in hearing. So the structures that we're talking about right now are just involved in hearing. Let's go down to the picture of the middle ear. It says air-filled mucosa-lined cavity in the temporal bone. And the inner ear is also within the temporal bone. We can also call this the tympanic cavity because it's associated with the tympanic membrane. Taking a close look at this really giant view of a very, very small space, we see our three little ossicles, and they're always in this position. We have the malleus, which is the mallet. We have the incus, which is the anvil, which is then attached to the stapes. The stapes is attached to the oval window. This is a very important arrangement because these bones form a bridge from the tympanic membrane to the oval window. We have two windows associated with this middle ear and inner ear that are in between the middle and inner ear. We have an oval window and a round window. And when you think of a stirrup or stapes, you can associate that with more of an oval structure, I hope. So the stapes is always associated with the oval window. It has a membrane over that. And the round window, if you notice, it's right down here. It's inferior to the stapes and the oval window. So these are two potential openings to our inner ear. And I call them potential because they're always covered with a membrane. Let's go in here. Openings associated with the middle ear. And I want to kind of highlight its potential openings. It's not true openings. External auditory or acoustic meatus, this area right here, sealed by the tympanic membrane. You can get a hole in the tympanic membrane, correct? Yes. And does anybody know what natural phenomenon might cause you to get a hole in the tympanic membrane?
Sinus pressure.
No, not sinus pressure. Kids have this a lot. Ear infections. An infection is a bunch of pus. If you have a bunch of pus in a mucosal-lined cavity feeding all that bacteria, it gets more and more and more, doesn't it? Sometimes it gets so big that it, poof, makes a hole in the tympanic membrane because, like any boil, a boil always feels better when it's draining, correct? And so that tympanic membrane can actually be a portal for actually loss of that purulent material or pus. Now, kids that have recurrent ear infections, we will put an artificial hole in their tympanic membrane, correct? Yeah, and why do we do that? We want to make sure that it gets proper drainage so we don't have recurrent ear infections, and finally the immune system and age will actually catch up and that will all go away. Because it's got skin on the outside and it's made of CT, it's got mucosa on the inside, you can put those little myringotomy tubes in there because as they grow, that little membrane will grow too and that will fall out. And so that's what happens with myringotomy tubes. They actually fall out and then everything seals back off because we know about skin, right? Skin will seal off, right? And we'll have a nice repair of that hole and you might have a little bit of scar tissue, but that's okay. A little bit of scar tissue is better than actually losing your hearing. Because if you have pus in there, what's going to happen to the ability of those ossicles to actually move or vibrate if you have a bunch of pus in that cavity? Yeah, it's going to greatly dampen it. And so that's why it's an air-filled mucosal-lined cavity. So if there's anything else besides air in there, it's going to have an effect on those ossicles because those little bones are connected to one another by little synovial joints. So these little bones have synovial joints also. We'll talk about how that can create a problem for you too. In our notes, back to those external auditory or acoustic meatus sealed off by the tympanic membrane or the borderline between the external ear and the middle ear. Oval and round windows, membrane covered openings between the middle ear and the inner or internal ear. And the auditory tube is an opening. It's a true opening, but it's most often collapsed until you do something like swallow. A pressure equalizing tube leading to the nasopharynx. So this goes to the nasopharyngeal cavity, basically back of your nasal cavity or nose. And the auditory tube, because it goes from the middle ear into the nasopharynx, it's called the pharyngotympanic tube, because we also call that middle ear the tympanic cavity. So pharyngotympanic tube. However, I actually know of it as the eustachian tube. So that's what most people will actually call it. So it's your equalization tube. So I'm going to tell you, most often is collapsed, except when you swallow or yawn. And you can sometimes hear crinkling in your middle ear when you have what would be in your middle ear to call crackle, crackle, crackle? Fluid, that's right. Fluid would be in that middle ear if you have some crackling. That's more commonly associated with head colds and allergies because you have increased production of mucus, correct? And so it's a mucosal line cavity, so indeed that will happen. As you swallow or yawn, that fluid will naturally drain inferiorly and medially for you, so it's typically not a big issue unless you're a little short kid with a short neck. And it's no longer having any sort of vertical plane to it. It's all horizontal and it doesn't drain too well on a horizontal aspect when you're upright. So let's talk about, before we go into the little ossicles, let's talk about that area. If it's infected, does it have pain or not? Yes, it does. It does. Okay, so I want you to think of that area. It's in bone, but I want you to pretend that the mucosal line cavity, the mucosa itself, is a balloon. Okay? And when you go up in the air in a big old airplane, what does a balloon ordinarily do as it rises up? It expands. Okay? So this is one reason why we have to have an equalizing tube to this area in bone. So it's a mucosal line cavity and has air in it, and when we go up and it wants to expand, somebody wants in, you open the door for them. That's what happens when you're late. So when it goes up,
we're sitting here thinking about a little balloon. We're like, oh, trees.
No, when you go up, when you watch those balloons that everybody releases for so-and-so and so-and-so, they all go up in the air and they all get bigger and bigger until they finally burst and then they fall down like trash. So, it's true though, isn't it? Yes. All right. It's not a nice way to pollute, but anyway, people do it for other reasons. So you're going up and the mucosa wants to go and stretch out. And so what will it do to your tympanic membrane if that little auditory tube stays closed? Push it which way? Out. That's right. It doesn't feel good. And so you notice you're getting some discomfort, and typically you try to pop your ears. Isn't that what the term is? Pop your ears? So that's venting your eustachian tube or your auditory tube. What you're doing with that maneuver is you're temporarily forcing it open. When you temporarily force it open, it allows for equalization of pressure. You guys follow that? That's why it's called an equalizing tube. And so you do that, and then because you have a head cold, you had a hard time, but you were able to do that because as you were going up, the nice thing about going up is it wants to push things off to the side. So that's cool, sort of. But then now you have to land. And so you were able to vent or equalize the pressure. That tube is collapsed again and swollen, by the way. And so now as you come down, that balloon, which was able to temporarily expand because of your venting, now what does that balloon want to do? Yeah, go inside. So which way your tympanic membrane want to go then? Medially, pulls on in. Does that feel good? It doesn't. So there are nerves associated with this surface as well as with the tympanic membrane, because remember, it is thin skin on the outside. And so as you manipulate it, it will actually cause pain. That pain is designed to actually make you vent your eustachian tube, but when you have a bad head cold and you're coming on down and everything's trying to compress, it's really hard to vent it. So most people with a head cold have more difficulty on descent than they do on ascent. And so that's why you hear all the babies crying on the plane, right? The babies are crying with ascent or descent. And that means, and also both sometimes, and that means, and they're crying is when they cry, that is venting their eustachian tube. So then on decent, however, they're having a difficult time, and you think that mean parents making your kids fly when they have a head cold. That's all I've got to say.
It was that or listening for way longer in the car.
Yes, I know. It's okay for the parent to have to listen to it, is my opinion. I'm not the parent, so I do not desire to listen to a wailing child. I'm too old for that.
They don't have like a soundproof partition in the back of the plane. All
No.
the place in the back.
No, they do not. So it's always best to think about that area as a balloon, going up and going down, and that the eustachian tube is usually collapsed except when you do certain maneuvers. You know, another thing you can do is you pinch your nose and you blow, right? And that's you trying to actually open up that eustachian or auditory tube to actually equalize things. Going to the ossicles, tiny bones connecting the tympanic membrane to the membrane of the oval window, and that's the stapes that's covering that. Malleus, that's the hammer. That's incus is the anvil, and stapes is the stirrups. And that's what it looks like to them, and that's the Latin terminology for that. Mentioned earlier, these are tiny synovial joints that connect the ossicles. So we have a synovial joint between the malleus and the incus and one between the incus and the stapes. What is a problem that we have sometimes with synovial joints? You get what with them? Arthritis. So if you have, and does that limit your movement? Absolutely. And so if you actually, it's very rare, but some people can actually have their hearing impacted by actually having arthritis of these tiny little ossicles, because these guys are supposed to vibrate at the same frequency as the tympanic membrane does. So synovial joints there are potential for pathology or problems. Now in this middle ear, it's interesting, we have two tiny skeletal muscles. That's not something that we're used to thinking about. But actually when you think about it, you do want to be able to voluntarily dampen the noise that you're going to experience, especially if you're lighting fireworks or shooting a gun, right? So if you know you're going to light fireworks or shooting a gun, you have this own little mechanism that you will actually employ to dampen the effect of this loud noise. And that's what these two tiny little skeletal muscles are designed for. We have the tensor tympani and the stapedius. So let's go ahead and take a look here. The tensor tympani, it has a little cut in it. So it's going from the auditory tube all the way to the malleus. And then the stapedius, right down here, the teeny tiny little stapedius is on the posterior wall of that middle ear to the stapes. These are skeletal muscles that when they contract, they will dampen the movement of these bones. And so that's actually how you dampen the noise intensity for those things. So tensor tympani, wall of auditory tube to malleus. Stapedius, posterior wall of our middle ear to stapes. This one is going to tense the eardrum. And this one will also dampen. Final ossicle. So these are a bridge for sound waves to actually travel mechanically. And so the sound waves will hit the eardrum, and then these guys will move at the same rate as the eardrum. And if we're having too loud of a noise, you can tense the tympanic membrane and you can tense the stapes, and so you won't have such profound movement on that oval window when there's too much noise. Internal, also called the inner ear, two main divisions. We have the bony labyrinth and the membranous labyrinth. The membranous labyrinth is inside the bony labyrinth. The bony labyrinth is inside the temporal bone, more specifically the petrous portion of that temporal bone. Our notes here say bone lined with endosteum. Endosteum is inside a bone that's not exposed to the outside world ever. And internal to that, so bone, endosteum, and then the next thing that we'll find is this fluid called perilymph. So bony labyrinths have fluid inside them called perilymph. What I want you to realize, this is like a snail shell, for example. We'll use that for the cochlea. Embedded within bone. You've ever been walking along the coast and picked up a piece of kind of a concretion material, and you see stuff that's actually stuck or embedded in that. So our bone has this vestibular cochlear apparatus, and the cochlea is the snail shell, embedded within that. And so we have this lining, so to speak, and that's what the bony labyrinth is. And inside this bony area, there's now a space that's lined with this membranous labyrinth. Our notes say there are membrane sacs and ducts within the bony labyrinth. And so we can liken this to a snail's body inside its shell. And when we are talking about this for cochlea. Let's take a look at the vestibulocochlear apparatus in the inner ear. It has 3 areas to be aware of. We have our semicircular canals associated with the bony labyrinth. Do you see? I call them hula hoops. Do you guys see why I call them hula hoops? Okay, so we have 3 hula hoops with each ear. Okay, and they're all plugged into this area. Take a look here, called the vestibule. So all the hula hoops kind of are plugged into the vestibule, which is a very important area too. Both the semicircular canals and the vestibule are associated with balance. The next thing that's part of the vestibular cochlear apparatus is the cochlea. And so we actually have, let's see, where do we have? Bony labyrinth cochlea here. So this guy here is strictly associated with hearing. The rest is with balance or equilibrium. In your efforts to draw histology for this, it's always a good idea to make sure when you do your histology atlas to have a kind of a low power picture so that you actually know where to go for the high power view. This here is a low power here in the cochlea because we want to take a look at the spiral organ of Corti in this area, in an area called the cochlear duct. It's in the notes, but I want to call it something else because it has middle vestibuli, scala media. That's right, scala media. Too much reading today. So the area that you're trying to actually more define in your histology is right there. And so drawing this area out, it's kind of nice to have a bigger view so that you know how to focus on down if you actually have a microscope and are taking a look at this area. Let's go a little bit more into the notes now since we've gone over the picture. Bony labyrinth, 3 parts describing, we're going to describe them in detail. The vestibule, which was in the middle, the semicircular canals, which we just described as hula hoops, and then the cochlea, the snail shell. Let's go up to the vestibule. Central egg-shaped cavity has 2 very important membranous labyrinthine sacs in there. So the sacs are the utricle and the saccule. So those are the membranous labyrinthine sacs within the vestibule. It's important that you actually realize that this is where we find static equilibrium receptors. And the name for these guys for static equilibrium is macula. Maculae for plural. So that's the vestibule, the central cavity. The semicircular canals are going to extend off the posterior aspect of the vestibule, and there are 3 of them: anterior, posterior, and lateral. Within those hula hoops, we have membranous labyrinthine sacs. The hula hoops, remember, are the cast inside what I call the bone itself. So we have the membranous labyrinthine sacs within those canals. They contain receptors for dynamic equilibrium. And this is going to be the cristae. So at the base of each hula hoop, which is plugging into the vestibule, we'll find a crista. Cochlea, snail shell. It will contain also membranous labyrinthine tubes, and there are 3 different ones to identify on a sagittal section of that organ itself, going from the top on down on it. We have the scala vestibuli, which contains perilymph, and then the scala tympani also contains perilymph. In the middle is the scala media, and that contains endolymph. So scala media has endolymph. It has a different chemical composition than perilymph. So it's important that you realize that endolymph and perilymph are 2 different types of solution, different ions, because that is going to affect our ability to actually create an electrical signal, which will travel to the brain for our hearing and balance. Scala vestibuli abuts the oval window. So it's on the other side of the stapes. Scala media, central, and contains spiral organ of Corti. I have a tendency to say the spiral organ of Corti. Most of the books call it the spiral organ now, but I have a tendency to use the complete name for that. That is where we'll call that our hearing apparatus, because that's where the transduction of a physical event will actually finally be transformed into an electrical event to go to the brain. If the scala vestibuli abuts the oval window, it's interesting that the scala tympani abuts the round window. It has nothing on the other side, just mucosa, because it's abutting into the mucosa area of the middle ear. That's on the other side. So here is what you want to look at, and more specifically, this is the spiral organ of Corti. So it's in the scala media or the cochlear duct. Indeed, our notes here also say contains endolymph. It has an important structure called the tectorial membrane. We're going to talk about that in a moment. And then it has these guys called hair cells. And the hair cells are responsible for converting a physical event into an electrical event. There are 2 membranes associated with the scala media. One is the basilar membrane on the base in which the spiral organ sits, and then the other thing up here is the vestibular membrane. It's just a simple squamous epithelial line that's actually separating the scala vestibuli from the scala media. The basilar membrane, right down in this area here, is indeed much thicker. So that's one way to actually differentiate the basilar membrane. So those are the histological components that come into play when we are actually now trying to actually create an electrical event and an appreciation for sound and music. So we're coming into the physiology of hearing. Sound is defined as pressure waves originating from a vibrating object, and that's what the tuning forks were helpful for in lab. It's to show you the tuning forks. You can see them oscillate or vibrate. And so what we actually have in our notes here, it says pressure waves. And so what you have to realize is as the tuning fork moves in one direction, it's compressing all that molecules in front of it, and as it moves in the other direction, it's decreasing the concentration of the molecules in front of it. And so those pressure waves are actually what's experienced on your eardrum. So sound is waveform. There's also another thing that's waveform in its origination, and that is light. Isn't light waveform? So we have light waves and we have sound waves. They both travel through, so basically sound travels through various mediums in waves. And it does it more slowly than light, correct? Sound travels at the speed of light? No, sound travels slower than light. With sound, we have alternating high and low pressure waves occurring. We have, with waves, we have some terminology here to make sure that we are on the same page. Frequency, amplitude, and wavelength. Frequency is defined as how many sound waves per unit time. Amplitude is the height of the sound wave. And then wavelength is the distance between two crests in a sound wave. So first off, let's go into which one of these three terms is loudness. Amplitude. Turning up the volume. So amplitude, height of the sound wave. So this is volume or loudness or lack of loudness. And that is typically measured in decibels, correct? dBs. Frequency, how many sound waves per time, and that is often referred to as pitch. So higher pitch and lower pitch. What is bass? Lower pitch, absolutely. And wavelength refers to frequency, correct? Distance between two crests in a sound wave. So if we have high frequency, what does this mean for wavelengths between our two waves? Short. It's nothing wrong if you're having difficulty memorizing this. For some reason, every now and then we hit up against a wall that we have some problems with. This is one that where drawing it out is really good. So if you want to draw out frequency, you would draw out big distances between the waves and make the height the same, and then you would draw out short distances between the waves as your way to remember frequency. Amplitude, short little waves, and then big waves is what amplitude is all about. Drawing things out sometimes works better than notes. Transmission of sound to the inner or internal ear. We all know sound typically enters the external ear canal, strikes the tympanic membrane, which will vibrate with the same frequency as our sound waves. This then causes the ossicles and oval window to vibrate at the same frequency. What's fascinating, remember our ossicles are just basically a bridge from the tympanic membrane to the oval window, and they vibrate like any sort of freestanding, poorly supported bridge. The eardrum is 20 times larger than the oval window. Remember where we are. We're in the middle ear. It's an air-filled mucosal-lined cavity. What's on the other side of the oval window? What kind of, it is scala vestibuli. What's inside scala vestibuli? Perilymph. So we are now trying to push water in a enclosed or closed cavity. So think of this. Think of a box that's sealed off and it's filled to water to the brim. And we have this oval window in it, and we start pushing on it. How easy is it going to be to actually push that oval window down and depress it? It isn't going to move at all unless you have a relief valve. Guess what the relief valve is called? It's the round window. So it's important that you realize the scala vestibuli is continuous with the scala tympani. And so as you push in on the oval window, what will the round window do? It will bulge out like an Audi belly button, right? So it will bulge out. And that's important because of doing this, you can create pressure waves inside this enclosed cavity full of fluid. And that's what's really important here. We need to create pressure waves. So pushing water is much more difficult than pushing air. And so this 20-fold size, or differential in size, multiplies the force on the oval window 20-fold. This is enough to start fluid moving within the cochlea. Even with that round window, we need this. And this is what this picture here is actually all about. And what we're going to try and do is we're actually going to try and draw this also in just a moment. So here it is, sound waves in the external auditory canal or external acoustic meatus. They're all basically the same. And these sound waves, alternating high and low pressure, are hitting, basically striking the eardrum or tympanic membrane. And it's going to then affect the movement of these ossicles, which will then affect the movement on the oval window, which will then start this fluid wave, which is what the little waveform is actually meant to show you. So we have a fluid wave that starts in the scala vestibuli first. And then this fluid wave at the area of resonance, which is based upon the frequency of the sound waves, will then take a shortcut, so to speak, through the scala media or cochlear duct and go into I don't know what happened with this part, but it goes into actually the scala tympani and then goes out that way. It actually makes it look like it's going into the bone, and it doesn't do that in this picture. Does that picture look like, is that off on yours too? I don't know what happened. The artist was obviously having vestibular problems that day. And mine even looks just worse than theirs, but it does the same thing, going through the scala tympani and then pokes out the round window whenever the other one, the oval window, goes in, and vice versa. So it goes in opposite directions. The interesting thing, the scala media is not activated when it first passes through the scala media, when we actually have this area of resonance where it goes through. It actually has to cause displacement of the basilar membrane, which is where the spiral organ of Corti sits. So it's the basilar membrane where the spiral organ of Corti sits that's responsible for actually causing the activation of the hair cells, which are part of the spiral organ of Corti. So let's look a little bit at this story of resonance. Resonance, where the wave generated in the scala vestibuli passes through the cochlear duct, also known as scala media, and generates displacement of the basilar membrane. So this is very important. It's not the vestibular membrane, it's the basilar membrane, because that's where the spiral organ of Corti sits. And so we are going to do our own drawing of membrane resonance. Let's see here. I'm making an oval window, and I'm making a round window, and I'm making a pseudo-looking test tube kind of a thing, connecting the oval window and the round window. And on the oval window, I'm making a stirrup looking kind of a guy. Between the oval window and the round window, I'll put the scala media. So we have scala vestibuli here. We have scala tympani here. And we have scala media, also called cochlear duct, here. And we have these interesting little guys called hair cells. And so I'm going to make it look like a row of hair cells. And they're columnar looking cells. And I'm just going to draw a few partitions for just a short period of distance and put nuclei at their base. So that shows that they're columnar cells. And then I'm going to do a tectorial membrane overlying that. So just another little line overlying that. And I'm going to actually have some hairs come off of these guys because they are called hair cells. They aren't true hairs, but they're called hairs because they look like hairs. So let me draw a couple of these guys. And so they are embedded in the inferior surface of that tectorial membrane. So the tectorial membrane and the hair cells are all part of the spiral organ. And so what happens with sound waves, based upon the frequency, so remember frequency is we have a lot of sound waves in a small area or very few sound waves. And the very few are bass or low pitch, and a lot of them are high pitch. So our sound waves are coming in, causing the tympanic membrane to vibrate, to cause the ossicles to vibrate, to then cause the inward and outward vibration of the oval window. And so based upon the frequency, that sound wave will actually go through, have resonance in a certain area of this spiral organ and push the the basilar membrane up, which will cause the hair cells to then be pushed into the tectorial membrane. So that's what happens. It's the base which moves up and pushes into the tectorial membrane, which then creates an electrical event. If the frequency is high, if it's high pitch, well, let me ask you. So I'm going to have you think about you're driving your car on a nice sunny day and the windows are down. Everybody's enjoying themselves and a teenager is coming and you can hear them. Why do you hear them? And it's not their muffler. It's the bass. Okay. Bass. And you hear them long before you see them, correct? Okay, so you hear them coming. So I'm asking you now, based upon that, which travels further down this spiral organ? High pitch or low pitch? Low pitch. So that's why I ask you to think about the bass, because you can hear them long before they pull up to you. And then you can start to hear the higher pitch aspects of their music, correct? So you hear the bass first, which is traveling a long distance before they pull up to you, and then you can hear the rest of their music, which has higher pitch aspects to it. So the resonance, where the wave generated in the scala vestibuli passes through the cochlear duct and generates displacement of the vestibular membrane, is dependent, where this little upward thing is dependent upon whether it's high pitch or low pitch. And that's what our little next picture is of. So it shows you low pitch actually can potentially go all the way out to the tip. If it goes all the way out to the tip of our cochlear duct, and this is also a nice picture too because it shows you the scala vestibuli and scala media are continuous with one another, correct? At this very tip area. If the sound wave is so low pitch that it goes all the way out and beyond that, because this one makes it look like it's actually displacing the spiral organ or the basilar membrane, goes beyond that, it has to go through, in order for you to hear it, it has to actually go through, like this guy does, the cochlear duct. Will you be able to hear it if it's that low pitch? No. And that's what dogs have, right? Dogs are able to hear certain pitches that we cannot hear, some nice low pitch things that we cannot hear. And if we were to try to construct our cochlear duct like the dogs, would we make it the same length? Would we make it shorter or would we make it longer? Longer. And indeed, that's part of what the process is, why some animals have a better hearing capability. Let's take a look and see what we can add to our notes. Summary of steps in sound production. So you guys pretty much feel like you understand this picture up here and then this little bit of information about frequency. 20 hertz. I guess I should have put that up in measurement of sound waves. Hertz is typically what we use for that. Hertz or VPS, vibrations per second, is a measurement of pitch or frequency. So 20 hertz, really long areas in between the peak of each wave versus 20,000 hertz. So we can hear 20,000 hertz to 20 hertz. So it's a pretty good spectrum. What happens if you destroy the hair cells in that area? You can't hear it anymore. What would cause destruction of hair cells in that area?
Really strong sound impulse.
Yeah, your stapedius and tensor tympani aren't doing a very good job for you, or you're a teenager, or you're not a teenager. Because I don't know about you, but I played my music really loud when I was a teenager. Anybody here not do that? Yeah. So what happens is, remember, it's frequency which causes it to go through this, and how intense that frequency is based upon the volume or the amplitude. And so you literally can beat them to death. When you beat them to death, you kill them and you won't hear anymore from that area. Back to the summary. Steps in sound production. Sound moves through the fluids within the cochlea. Yep, we already did that in waveform. High frequency sound, which means high pitch, activates, what's interesting, the hair cells are actually stiff close to the oval window. In other words, it doesn't travel very far. Low frequency sound travels further, as we talked about the teenager and their music, and activates, what's interesting, those hair cells have floppy hairs distally. It's kind of a strange situation. It is the vibration of the basilar membrane that is responsible for triggering these hair cells. And we can detect 20 to 20,000 hertz as far as sound goes. So that's sound. Now we need to do equilibrium and head movement. We have the vestibular apparatus, and then we have the semicircular canals that are responsible for equilibrium and what happens to our equilibrium when our head moves around. We're going to first talk about the one next to the cochlea. That's the vestibular apparatus. It is going to contain receptors for static equilibrium, but also linear acceleration. So this is gravity and riding in your car, right? Up and down the elevator and zipping along on the streets. So static equilibrium. So when you take a look down, we're at your toes. We're actually activating the vestibular apparatus. When you look up at the ceiling, that's also a vestibular apparatus activation. So linear acceleration is also part of that. So where you move your head in the plane is vestibular apparatus. The receptors are called macula, and they are inside these labyrinth sacs called saccule and utricle. And they help us with our vertical and horizontal plane activation. The macula is composed of support cells, helps to keep the hair cells, which are the functional cells, which are the transducer of a physical event into an electrical event, happy and functioning. Overlying this collection of cells is an otolithic membrane. Otolith means, oto is ear, lith is stone. So you do have rocks in your head called otoliths. They're little calcium stones embedded in the otolithic membrane. So calcium stones, they are designed to add weight to the otolithic membrane. Which is going to help to create inertia or drag, increased drag. The otolithic membrane, because I'm going from the stones to the membrane, the otolithic membrane is a jelly-like substance in which the hairs from the hair cells are embedded. The hair cells have sterocilia, which actually are microvilli, and one kinocilium per hair cell. And we're going to now take a look at how we activate these guys. Macula, respond to changes. I want you to understand all of this is changes, whether we are dealing with static or dynamic equilibrium. Macula, as well as our crista, all respond to changes in our body position in real time in a gravitational area. Changes to body position. So gravity and linear acceleration. Are going to be what the macula measure. Here is a cartoon picture of the macula. And we're going to draw our cartoon version of this. So draw like a basement membrane area. Draw a ridge of cells. Make them look columnar. And I'm making them kind of fat because I want to be able to draw my kinocilium and sterocilia. So what we're going to do here is we're going to draw a tall guy and we're going to draw some short guys next to him. A tall guy and some shorter guys next to him. Tall, that's our kinocilium, and then our sterocilia are next to him. And then we're going to put on top of that the otolithic membrane. So kind of a jelly-looking stuff. We're going to put stones in it to add weight to it. And so we're in a car, and we're going to go forward. So physically, we're moving in that direction. This is an area that's full of endolymph. So when we move in that direction, what's going to happen to the otolithic membrane standing on top of these little cilia or hairs inside this fluid-filled area? Opposite direction. That's absolutely it. And if I add more stones, what happens to the drag on this and inertia? More stones I add, the longer it takes for it to move, correct? But then it stays moved, it stays off of its center area for a longer period of time. Take stones off, lighten it up, it will move sooner, but then it will also equalize sooner. And so that's what these otoliths are for. These otoliths are to help have this certain amount of inertia, slowness to start when we move, and then also prolong that movement. And that's an important aspect because whenever this moves in this direction, that means we're having an effect on those guys down there. And I'm going to let you know these are mechanical gates in these hair cells. And mechanical gates means something physically opens a door. And I'm going to tell you the story about that. With that kinocilium right there, he's got a little rope that's going to the doors on every single one of those little sterocilia. So he's got a little rope that goes to all the doors. It's attached to all the doors. And so when this guy right here is, this otolithic membrane is moving in this direction. Let me erase the other one. He's pulling those doors open. Can you guys follow me with that? So when these guys are, you can say, are following him, but in other words, he's leading the way and he's pulling them along and he's pulling their mechanical gates open. If he were to go in the opposite direction, because this is indeed what happens, if it was to go into the opposite direction, what would happen to those gates? You'd be closing them. And that's what happens with these guys, with their mechanical gates. So the kinocilium has a rope hanging on to all the doors, to all of those little sterocilia, and depending upon which direction he moves, he will open or close those gates, which will then create when he opens the gates, then we actually have an inflow of ions, which you guys know all starts an electrical event. So that's why the endolymph is important in its actual chemical composition. Down here in the notes about macular activation mechanism, mechanical gates, which we just talked about. And if you're just sitting there like you are right now, we have this type of signal frequency going to this area of your brain that's responsible for giving you the perception of static equilibrium. Then, when you pull things away, we will get this excitation. So as the kinocilium is pulling the gates open, pulling the guys with them, we will get increased output. That's a change. But you guys know, after a while when you have your head back, you don't think about it anymore because we're not changing anymore. And remember, it's drag, but after a while it goes back into its position. And also when you're like this, if you're weighted down, if it's the one that's on the horizontal plane and you're doing this to it, it's going to stay back that way, but it stopped changing. So it's important that you understand the activation is a change. So when you first went from horizontal to basically a slant, that was a change, but then the change stops, and then you end up getting back to this standard output. If you look in the other direction, which is what this one here is actually showing, you also get information where you're closing the doors, and that provides inhibitory information to this area of your brain. And so you perceive that you're looking down, or you perceive that you're looking up. It's not just what you do with your eyes. If you close your eyes, you know you're looking up, and if you, with your eyes closed, you know that you're facing down. So, and that's all because of our static equilibrium receptors of the macula in our saccule and utricle. Angular acceleration has a similar process, but it doesn't have an otolithic membrane. It actually has what's called a cupula, which is a gel-like mass with no stones. So the crista, or crista ampullaris, contains support cells and hair cells, just like what we did with the macula. When we talk about angular acceleration, I'm talking about spinning and roller coasters. Receptor, which is down below, is crista ampullaris. It doesn't hurt to write it out because it helps with memory retention. And this is found at the base of the semicircular canals. So spinning or rotational, I guess would be another word for that, yes? Effects, and that's also roller coaster because it's all over the place for you. Similar apparatus, it's the bending of the stereocilia. That's important for the activation of the hair cells. In order to, here they are in the connections here with the vestibule, in the ampulla, which is a swelling at the base of our semicircular canals. In order to activate our cristae in the semicircular canals, we need our endolymph to move in the opposite direction so that we bend our hairs to depolarize them. When we move in the opposite direction, we will cause hyperpolarization. So realize we get depolarization when we open the gates, and we get hyperpolarization when we close the gates. And that gives us information about the amount of action potentials coming to this portion of our cortex. I don't know why that's, should be a 3. Krista, also, they respond to changes just like the maculae, but without otoliths. They don't need that. So we can draw our little semicircular canal with a speed bump in it. Put our little cupula. Oh. Let's make some kinocilium. And our little cupula on top. It's still gel-like. So when you are doing a somersault and you're going this direction, what direction does the fluid move?
The opposite.
The opposite direction. So the fluid will move in the opposite direction. Whenever you are doing any of these angular accelerations or decelerations, you always have at least 2 crista activated. And why is this so? Why is there always at least 2?
Just due to the planes that they're set on.
So an anterior posterior or an anterior and lateral? Is that what you're saying?
So they take 2 years.
You have 2 ears. Yes. Isn't it funny when the simple answer eludes you? It really is. So whenever you're doing a maneuver, you're always going to be activating at least 2 crista, because if you're actually doing a somersault, you're not leaving one ear behind, folks. You're going to take both of them with you. And same thing with cartwheels and things along that line. So you'll always activate a minimum of 2 crista. And it's this activation that will actually tell you, that you're having that angular acceleration. Then when you stop, what happens? The other nice thing about this, which is that spinny chair thing that you guys were doing the Baronet test. So when you spin, 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 what do you know about the fluid inside that area? It has inertia too, doesn't it? So it has inertia, but it catches up with you, right? So eventually the fluid's moving with the mechanical canal that it's within, correct? And then when you stop that canal, the fluid keeps on going and is actually then going to make this little guy here, because initially it makes that guy move in that direction, but then when you stop, makes it go in the opposite direction, correct? Good. So you have stopped, but now the fluid is still moving. And so that's another reason why you feel like you're still spinning, correct? Because the fluid is still moving.
The fluid's going to keep going in the same direction. So your crista is going to be the same way even after you stop.
Well, ultimately, as you're moving, initially, our fluid's going in the opposite direction. But because of the friction on the walls in this little tube, then that fluid will start to follow you. That's why it requires you guys to spin for a while. You guys follow me with that? So when you spin for a while, because if the fluid's moving in the same direction that you're moving, you've been spinning for a while. Because the walls provide friction, and ultimately the fluid will then be actually coerced to move with you. You guys follow me on that? And so when the fluid is moving with you or staying in that area of the canal, and then you stop movement, you come to a stop, then the fluid, which is now moving in this way, and then you stopped moving, then you're going to make that cupula move in the opposite direction. Make sense? So may not make sense at this moment, but if you think about it, whenever you actually spin something around and it's got fluid in it, the fluid ultimately will actually start to stay within the cavity that it's spinning with. But initially, the inertia of the fluid will actually make it feel like it's activating things in the opposite direction. That's what that Baronet test was all about. So that's the end of that chapter. Our next chapter is going to be the endocrine system. So make sure you bring those notes so that we can actually go through that one at a fairly rapid click. We'll stop there.